and transitions. After graduating from the University of Texas Health Science Center, Kilty Brown moved to Wyoming to embark on a career in healthcare. She may have come for nursing, but she grew her roots in Wyoming out of a love for the state. As a nurse, Kilty worked across the continuum of healthcare until she found her passion in hospice and palliative care. As the executive director of Central Wyoming Hospice and Transition, she leads the oldest and largest hospice in Wyoming. Kilty is active in palliative care community and has presented nationally on utilization of hospice facilities. She has a master's of public administration from the University of Washington, earned a certificate in public administration or palliative care from the National Hospice and Palliative Care Organization, and is a Leadership Wyoming alum. She gives back to the community through Meals on Wheels and the Casper College of School of Nursing Advisory Board. Whether she's backpacking in the Bighorns, skiing in the Alps, or trekking Everest, Kilty loves sharing new adventures with her husband and children. Please welcome Kilty.
Thank you. Can you guys hear me? I have a pretty weak, soft voice, and so I just want to make sure I'm doing this right. Speaking about sharing adventures with my children, I did bring one of my children with me today, so she could see everything that's going on here in Cheyenne, and so I just wanted to put a shout out there to my daughter, Emily. So I want to thank you all for the very gracious and welcome that you've given me this morning. You know, my specialty really is hospice. And I got to be honest, I'm a little bit nervous coming up here to talk something that I consider way bigger than hospice, which is palliative care. For one thing, I don't know that I 100% consider myself an expert in this subject, but to be honest, I don't really know that there are experts in the state of Wyoming. And that's really one of the things I want to talk about today. But first, before I get going, I kind of, if you don't mind, like to get a sense of, you know, who we have out in the audience here. So can you raise your hand if you're a doctor? Oh, our one representative out there. How about any nurses? Okay, that's awesome. Social workers? Great. Actually, I love social workers. I don't understand them, but I love them. What about cancer survivors or families? Okay. And I would put myself in that one too. And advocates. Okay. So I heard it was a mixed group, and I just wanted to see so that, like, when I'm talking, I don't want to, you know, go in the wrong direction here. But, you know, I'm just going to give an overview of palliative care. I realize for some of you guys, this might be a basic, you know, like refresher. And, you know, if you give me some grace with that, I appreciate it. But I want to make sure we're all on the same page. And then I want to talk about, like, what does palliative care in Wyoming look like? And, you know, what are some of the barriers? We have a very unique state. And trying to get palliative care out there is difficult. It's challenging here. And, you know, what I see, and I'm going to say this is only my opinion, on different ways that we can go forward. So defining palliative care. Man, if you go and Google, their definitions are like a page long. And I thought maybe I'd come up here and read it. But it's like 4 or 5 paragraphs from different people. And I think actually this might be one of the problems why when you go out in the community and you go palliative care, people don't understand what it is. It's not hospice care. It's not the same. It's supportive or comfort-focused care. In many cases, you know, it's care for the seriously ill. A seriously ill person is somebody, I will read this, that has a health condition that carries a high risk of mortality and negatively impacts the person's daily function or quality of life. So we're talking about cancer. We're talking about advanced respiratory disease. We're talking about advanced cardiac disease, liver disease like my mom had. One of its main focuses is pain and symptom management. And we'll talk a little bit about that too. But it's also to preserve quality of life. How well are you functioning? How well are you able to do the things you enjoy? Can you get out there and can you interact with your family? It should be holistic. family directed. A lot of times we talk about patient-centered care. Coming from a hospice background, I believe heavily in family-centered care. And it should support decision-making. You know, this should be about what are your goals? And sometimes as a nurse, my goals are not the same as a patient's goals. I don't know if you've realized that, if you've ever, any of you who've taken care of patients, sometimes they're not the same at all. Sometimes I want something for a patient and that's not what they want. They want to live home alone. And I'm going, oh, that's unsafe, or that doesn't feel good. But how do I respect somebody and how do I acknowledge their inherent dignity? And sometimes that means that I have to give that up, and it has to be, you know, their decision and not mine. So, you know, a great question is like, you know, what's your goal? What's the most important thing to you? You know, I'm thinking as a nurse, man, it's gonna be my pains of zero, right? Theirs might be, I want to go to my granddaughter's wedding. Okay, that's great. So how do we get you there? You know, to go there, you can't be tired. I mean, you want to be able to enjoy it. So we need to talk, how do we keep you from being, how do we preserve your energy? You can't be in pain because you're not going to enjoy the wedding. So how do we get you comfortable? How can we make sure that you can breathe when you're there? And so these are different things and different ways that we can align our goals as caregivers with the patients. But in order to do that, we have to ask the right questions, and we have to be willing to listen. And that can be tough. So, okay, so I have a little bit of quiz because I think, you know, I do this with nursing students all the time. And I go, what's palliative, what's curative? And since you guys are all experts out here, I'm gonna throw that out. So I'll throw out something and you tell me if it's palliative or curative, and you get the difference. One is symptom management, one is curing a disease. So antibiotics. I hear a lot of curatives. I heard one both. Let me ask you ladies out there, have you ever had a UTI? That's painful, right? If you have cancer and you have a UTI, you know, are you going to cure the cancer? So, you know, who is the both out there? Yay. Yeah, absolutely. What about radiation? I saw somebody back there mouth something. Lisa was mouthing both, right? In some cases, we're using radiation because we really are trying to get rid of the tumor. But what if you have a tumor that's pressing on the spinal cord and maybe you have metastasis all over? You know, if we can just shrink that tumor a little bit and we can relieve the pain, we can get maybe better functioning and not fall where it's not pressing on the spinal cord. You know, aren't we improving quality of life, right? Okay. Tube feeding. This is a tough one. And I'll tell you, my staff struggle with this one. I heard somebody say both. You know, both, it depends. I think those are both great answers. And I guess you guys get where I'm going with all of this, right? It really depends on the patient. If you have a little grandma, and I always go to the little grandmas who are like 90 years old and they look like a little bird and they're really, you know, having failure to thrive, and they're not living because their body's tired and they're giving out, and that's natural. That's one thing. I mean, it feels almost inhumane to put in a tube feeding at that point because they're doing what they're supposed to do. But what if you have and I had this very recently, what if you have a 50-year-old with throat cancer and they just have that obstruction and they can't eat, you know, and maybe they're even still hungry? Man, that would not feel good not to give them tube feeding. And so I guess the point of this exercise really is I want us you guys are going to be like the leaders of palliative care in Wyoming, is to really expand your idea and not put it in a box of what it is and what it isn't. Did I say I love doing that with the nursing students? It's so much fun. Okay, so case study. And this is a cheater. It's not really a case study. So 79-year-old female, and she's been really tired, her stomach's bloated. She goes into the doctor's office and, they're going to palpate and feel around, and it feels hard, and very concerned it's ovarian cancer. She goes in for surgery because the plan is they're going to debulk. They're going to take out as much cancer as they can, and then they'll do chemo and radiation. They get in there, cancer's all over the place. And she did pretty well, but it was more than they expected. She's a widow. She lives alone. She does have a daughter. One daughter's died, but her other daughter lives pretty far away, lives about an hour away. And so after this, it was a pretty intense surgery. She has to go to rehab. So imagine this is Wyoming, and your grandma, your 79-year-old patient's living in Douglas, and daughter is living in Casper, and imagines the winter. Who's taking care of her? She ends up having to go to the LTAC. She's not doing so great. She doesn't really want to get up. She's tired. After that, she, this is a long progression. It's a long story, but she throws a clot, and because, that happens, and it ends up in her lungs, and she has a PE, and she ends up in that LTAC, not an LTAC, it would be like Elkhorn, a rehab hospital. She ends up there for, a good 5 weeks. Who's visiting her? Because again, it's winter, and, daughter's someplace else. Going on, she gets better. She starts chemo. She actually is feeling great. Her CA 125, did I get that right? I did. I thought so. Is going down, trending down, but she gets C. diff, right? And she gets really sick, ends up in the hospital. As the course goes on, it's just like this up and down roller coaster, and she just becomes a little bit more debilitated, Cancer's a battle. And this lasts for, a good 3 years. She's evangelical. She believes in faith healing, so, going on to hospice is not an option. She's going to fight this. And to be fair, she had some great Christmases, right? Great times with the families. In the end, finally, she's too weak to be going to the doctor for chemo anymore. And somebody says, maybe we should do palliative care. 2 weeks later, she's on hospice. 3 weeks later, she passes away. When should have started having some palliation? When should we be giving her some symptom management? At the beginning? Yeah. It didn't happen until 3 years later. What needs to be palliated? What symptoms are we going to be addressing here? I might not have been really great on giving you those details. So I just want to tell you, this is a case study. It is a case study. This is also my grandmother. And this is real stuff that happens every day. So we'll talk just a little bit about symptoms. Does anybody have any questions so far? Okay. Oh. So have you guys ever heard of Dame Cicely Saunders? Oh, really? So I was actually Googling her a little bit. Coming from hospice background, I've heard a lot about her. She's the mother, I'm going to say mother, of the modern hospice movement. She came from England in the 1960s. She said, hey, what we're doing just doesn't feel right. She was first a nurse, then she was a social worker, and then she became a physician. And she started hospice, and then, ultimately started palliative care. And one of the things she said was one of her theories or frameworks was this idea of total pain, that a person is not just one disease. And when they're suffering, there's 4 domains of suffering. And in order to take care of it, we need to treat all of that. So this is where you say, your patient in 504 is not that COPDer, they're Mrs. Smith, with a full person. And so there might be physical pain at the end of life. There might be psychological pain at the end of life. And I've seen this. Psychological pain, there's anxiety, there's depression. There might be that they haven't talked to their kids in 10 years because they were an alcoholic parent. There might be social pain at the end of life, and I've seen this where it's a 50-year-old and he's got twin sons and he doesn't know who's going to pay the gas bill. And there might be spiritual pain. Somebody who hasn't talked to God in the last 20 years, and now they're having like this big crisis, what does it mean? What happens if they die? Where are they going? And so, that there might be this loss of meaning and angst and even existential suffering. So there was a study that was done, and it was a little bit, probably back in the 90s, but they said, for a cancer patient who is in inpatient hospital, they averaged 12.5 symptoms of these symptoms. If they're outpatient in the community, it's 9.7 of these symptoms. So, how are we taking care of these patients? Are we addressing all of it? So, there's some take-home points, and I'm going to be honest, I stole this from the Stanford Palliative Care website. It's a fabulous resource, but most Americans die of chronic diseases. We were just talking about that. It's not acute diseases, it's these chronic diseases these days. Most will die in a nursing home or a hospital. Almost 1 in 2 patients who die in hospitals and 1 in 4 patients who die in nursing homes die with pain. We're not doing a great job. A lot of families express dissatisfaction about the end-of-life care they receive with their loved ones. However, if we start giving appropriate palliative care early in the illness trajectory and hospice care in the last 6 months, we can improve lives. In some cases, people live longer. And the thing to know is, if we start palliation at, the day of diagnosis, these people who are living with chronic diseases, they're living with them for years before dying. So what's happening in those last 5 years? What's that life look like? So, okay, we painted a picture, we got a problem. So what's the solution? I mean, it should be pretty easy to solve, right? We integrate palliative care with conventional medicine. Palliative care can start while you're still doing curative care. We can increase access to hospice care with those with less than 6 months to live. We're going to recognize that there's total pain and that's a whole person. So we're going to have an interdisciplinary approach. I said, like, you social workers, I love you. I don't understand you. It's so true. I'm a nurse. Like, you guys live in a different world than I do, but I respect that. You guys deal with things that I can't. I don't know if you've seen like literature on this. Teams always make better decisions. So we're going to approach this patient as a team. That might include a chaplain for their spiritual, a social worker for social, psychological, counseling, obviously a doctor. It might include a dietitian. How do we preserve function? How do we optimize their nutrition? Why not a physical therapist? How do we keep you safe? How do we keep you walking as long as possible? How do we keep you from falling? These are all things that we should be doing, and we should be talking to the pharmacist. We're going to put the family at the center of the decision-making process. This isn't our road. It's not our journey. It's theirs. Oftentimes they know what's best. And when I say family, I don't mean patient, because, after all said and done, it's that family that's going to judge us. And lastly, this is my favorite one. I'm really working on this one. We're going to create opportunities for training, basic and advanced palliative care for all healthcare professionals. I'm actually working on that. Lisa is too. So again, I stole this one from Stanford. And you know what I would say is my grandma had that top model of care. We're gonna cure. We don't go see the specialist. All of a sudden, it's like, hey, it's time for palliative care. And then we're going to put you in hospice, and that's kind of it. But I got to say, even those 3 weeks of hospice was such a relief for my aunt. She wasn't a caregiver. She wasn't a nurse. Even me as a nurse, I didn't know what to do. Like, that wasn't my type of nursing. And so it was so great to have somebody walking alongside you. What I really love about this bottom one, and this is what they say the optimal model, you notice they start palliatives on the bottom, curatives on the top, and they start palliative at day 1. And it's not like, a lot of times you see this diagram that's like this straight line. And we all know people don't go in straight lines, right? I mean, especially if you're in Wyoming, like, you're going to tell me I'm going to go in a straight line. I'll show you. So, there's way up there when we're in, the rehab. There's way down here, when we're going out for Maggiano's dinner together. And you have these ups and downs. And sometimes you need a little bit more and a little bit less of one or the other until you get to the end. But it's the idea that they work hand in hand in tandem. Any questions so far? Okay. I keep confusing myself. I keep on trying to go for the mouse, but I really do love this. So what do you guys think? How do we do palliative care here in Wyoming? I'm not seeing a lot of it, I'll be honest. And I do want to talk, some of this, I ended up getting here, I'm pretty dang sure, through Lisa Eads, because that's the only way anybody would know my name. But, I met Lisa through the governor's palliative care. Is it a task force or a advisory council? And I want to start with that. So Wyoming Statute 35-1-1201 to 1205. I think the best thing about this is this created a legal definition of what palliative care is in Wyoming. Because I think this is going to set the ground rules of what it could look like, right? So I will read this one. Patient and family-centered medical care that optimizes quality of life by anticipating, preventing, and treating suffering caused by serious illness. Palliative care throughout the continuum of illness involves addressing the physical, emotional, spiritual, and social needs of the patient, facilitates patient autonomy and access to information of choice. These are all things we've been talking about. Palliative care includes, but is not limited to, the discussion of the patient's goals for treatment, discussion of appropriate treatment options, including hospice, pain and symptom management when appropriate. And I'm going to skip down. The goal is to reduce adverse symptoms, reduce pain and suffering, improve quality of life without by itself seeking to cure the illness, prevent death or prolong life. Just to be clear, they want to make sure we all know it is not meant to hasten death. So, that's a pretty comprehensive definition. I mean, it says that we have to have a whole team here. So everybody in this room, it says that we have to give them patient choice. And like I said, I love the fact that we have this, because I really do see palliative care being incredibly relevant in the next 10 years, especially with our aging population. We have the second fastest aging population in the US. We're going to need this one way or another. So it also established the Palliative Care Advisory Council to advise and consult and to help the legislature and the Department of Health. And then it directs the Department of Health to publish resources. And I saw Star walk out on that one. So So what did they do? And Lisa, you are welcome to jump in because you have a better idea than I do. This came from the report that you guys. So Lisa was on there. Dr. Greg Moreno, who is an oncologist. I think he was in Sheridan at the time. I think he's moved on to someplace else now. One of my nurses was on it, but they wanted to see what's the sense, what's going on out there. And I got to say, it's hard to figure out because there's not a big portal where everybody jumps in and says, yep, I'm doing palliative care, or yep, I know what it is. And with these big, long definitions, nobody knows what it is. But 47% of the respondents had some experience with palliative care in their life. So they had a feeling of what they did. My gut tells me, just from doing the work I do, that if you dug in, they probably didn't have a deep understanding of it though. They also found that there's a lack of access to info on palliative care. And this is really a lack of education. And one thing that came up is a lot of people are scared of palliative care because A, they think it's hospice. B, they think they're going to put you on morphine and you're going to become addicted and there's an opioid crisis. And so they're scared of the pain control. Or C, they think it's like that it leads to physician-assisted suicide or, euthanasia. I mean, you see that even in the language of the bill that they felt like they had to put that in there. And I do think there's something, palliative's a long word. I mean, what does it mean? Maybe if we just said this was supportive care, people would understand better, right? 55% of the providers never had any training in palliative care. I mean, I'm even talking about a CEU. They've never done anything. Now you think of it, when you're a cancer patient in Basin, you don't get to have a choice of, who's going to be your doctor. Your doctor's there. You can't be like, okay, can you show me your certifications? Can you tell me what classes you've had? So I'm going to talk a little bit about what I know about where we're seeing palliative care. First one is hospices. This I know. We're a type of palliative care. I think we do a great job. I think my team does a great job. We do provide that interdisciplinary stuff. But here's the deal. In Wyoming, only 42% of Medicare decedents or anybody who dies in the last day receives hospice care. Right next door in Utah, it's 99%. Why is that? Is it because we're independent cowboys who don't want to take any help? Or is it because we're so rural that there are literally black holes where there are no providers who are experts in hospice? I've heard stories from Rocky Mountain Oncology that they have patients who are in LUSC and they're having to talk to them over the phone and tell them how to give their loved one morphine because there's nobody there who can do it. Hospitals. Well, we'll talk about that just in a second. Community-based. What community-based means is that you have somebody who's in their own home and you are going out, the team is going out to the home to provide care. That could be, if somebody's living in assisted living, a nursing home in their own home. To me, this is ideal. Think about it. The patients you're talking about who are seriously ill, they're tired. It's hard for them to get out. Going to them makes sense. Are we doing okay on time or do I need to speed it up? Okay. Oh, perfect. And then lastly, primary care and specialists. And this is where I see the majority of it happening. It's probably not that team aspect. It's probably the physician who's doing their best to take care of the symptoms. Especially in these small towns, they know them really well. They know what's going on at the home. I got to say some of the best palliative care I see done by clinics is probably the oncologists. I think they understand a lot of this. But what happens in the middle of the night, if the patient's having an emergency, do you have a team who's able to respond? So this came from this is for hospitals, and I just threw this up here. The Center to Advance Palliative Care is a 2019. They do a state-by-state report card. By the way, Wyoming got a D. And I really want to say this is the hospitals that they say have palliative care in the hospitals. I think this is overinflated. You know why? Because I come from Casper, and I know that 1 of the 2 out of 2 does not do palliative care there. But I mean, you look at it when you're talking your critical access hospitals, you know, only 4 of them provide palliative care. They report that they provide palliative care. Only 1 out of 6 of a 50 to 150 bed hospital. And, you know, of your 2 major ones, they both say they do. But I think Wyoming Medical Center gave it up a few years ago. So the question is, why is it so hard? Why do we have a D? And I think there's some really big barriers and some, I mean, there are probably reasons you guys could just throw out at me. I mean, I'm sure you know what we're rural. Number 1 is clinician training. Okay, in 2019, that state report card, only 6 doctors in the state were certified in palliative care. Only 12 nurses. And I'm going to tell you, half of them were probably mine. You know, and to be fair, there's people who are practicing palliative care that don't have that training, but it's not something that's required. I think UW Family Practice is doing better. You know, I know that Casper College, they're making it part of the curriculum, you know, that all of the nurses go through it, but I think it's very hit or miss. And you also have all these other doctors. And does, you know, a 1-day class or a 2-week rotation really make you feel comfortable with providing it or having those conversations? Maybe not. Payment source. Okay, so I've been a director of a small healthcare agency for 5 years now. And what I've discovered is if there's not a way to pay for it, medicine doesn't happen. And there's not a great way to pay for palliative care. I think that could be changing and that could be on the horizon. But, you know, they have some, and I might get this wrong, like chronic care, case management, but it pays very little for a month. Doctors, okay, you're supposed to have this whole team, right? That's supposed to be going to see these patients. Your chaplain, you can't bill for a chaplain. You can't bill for an RN. You can bill for that physician, but there are so many regulations on what that documentation has to look like. You know, you can only bill for the social worker if they're an LCSW, and then you're billing for basically therapy. So how do you do it? I mean, how do you provide what we know is high quality care, what we know is best practice, if you can't afford to pay your people? And I want to say the other thing is, and this goes to the next thing, small populations. Whew, you're paying your people if you've got 2 patients or you've got 100. And I've done some, I did a class on this, but there's the recommendation, the standard is like, you know, if you have a nurse practitioner who's actually, or maybe a PA, that they're seeing 100 new patients a month. If you're in Thermopolis, are you going to have 100 new patients a month? Yeah. I mean, I know this as a hospice provider, it can be tough for me going to Douglas, you know, to pay a chaplain, to pay a social worker, to pay a nurse. I mean, again, you know, I like Basin and Thermop. I don't know why I go there. How do you support that? I mean, I think we have some real challenges. And then the rural state. What if you're having to drive 60 miles to see your patient, or your patient has to drive to you? And again, you're talking about somebody who has fatigue, who's shortness of breath, who has anxiety. Are they even able to make that trip? Either way, if they're coming to the clinic or you're going to them. So you can see, like, these are some tough things. And this is not, we're not going to take our answers 100% by looking at New York or California. In fact, Utah might be different than us. I say that, and then I'm going to throw out a California thing later. So that sounds really depressing, right? But I gotta say, I do see some hope on the horizons. That's why I think it's really important that we're having these conversations right now. I think, in fact, I know palliative care is coming, good palliative care. There's some legislation going on nationally. Lisa's gone out to DC to talk about it, but PCHETA, the Palliative Care Education and Training Act, that's federal money to train our doctors, our nurses, our social workers in palliative care. It also provides some money to provide education to the community so they know what it is. This one is really, really close. I'm really surprised it didn't pass like a year ago, or I think it got tied up because of COVID and budget stuff, but that one is coming. The next one, this is pretty awesome. You guys should feel proud about this. This is the Expanding Access to Palliative Care Act. Senator Barrasso is a sponsor of this. He's a real hero for the medical community and for hospice, for palliative care. But what this does is tell CMS, hey, you guys got to come up with a way to make palliative care pay. And you have to come up with a demonstration model. One of the things, what it looks for is that it's a test model for community-based palliative care, meaning you go into the homes. You have to have multidisciplinary team. And you have to be able to have some on-call support 24/7. And we're going to help you pay. We're going to help pay you for this. Medicare can do it without the Congress, but Congress telling them, it just puts more pressure on it. I'm telling you, I'm really sure this is all coming. If you look nationally, every place else is going towards having a palliative care model. And why? Because it works. It's better care, better satisfaction, better outcomes, and it actually saves money. There was a big study that came out, I think this past week, and I was trying to Google and I couldn't find it before coming up here, that showed that hospice and palliative care has, over the years, has saved Medicare money, even if somebody comes on in the last 3 days of life. But when you look at the months leading up, it saves money. So that's just a talking point when you talk to your legislators. So, okay, this is the slide I told you. Somebody in here is going to be angry at every single one of these. And this is my opinion. I'm not putting this on anybody else. Number one, possible ways that we could get palliative care here in Wyoming: training. Make it a part of the curriculum of the nursing, social work, medical schools. I can see a difference when I have those Casper College nursing students come through. It's like, they get it. And they might not come and work at Central Wyoming Hospice, but they're going to go to a hospital, they're going to go to a nursing home, and they're going to take that knowledge with them. And they're going to be advocates for their patients. Require CEUs. I guarantee you, my doctors hate this. My husband's a realtor and he hates CEUs. But the thing is, sometimes if you don't require it, it doesn't happen. I mean, there's a reason why my husband has to take an ethics class every single year, because he needs it. But because our physicians need it. They need that training in palliative care. And I'm going to tell you, they do need it. You know, I had this down in my notes earlier and I forgot. When we talk about physician discomfort and having these conversations, my team went over to the ER at Wyoming Medical Center recently, and they were talking hospice, and a physician who has been there for probably a good 20 years came up to him afterwards and asked my nurses, how do you have that conversation? I mean, he's seen thousands of patients. I was in Memorial Hospital of Converse County this past week, and they said, that's great. You guys can come in here and you can do this, but you're going to have to educate the doctors. They don't know how to dose. They're just not comfortable with it. I'll tell you, I had an oncologist in the last couple of weeks that said, I can't handle their pain management anymore. I don't feel comfortable with what that patient needs. We need to be educating our physicians. And I apologize, This is not with disrespect. It comes from a place of love. Yeah. Focus on primary care. Palliative care might not be possible in every community because we're so small. But what if we can get the primary care physicians on board? What if we can get them comfortable? What if we can provide them resources within their clinics in Basin and Thermop? What if, and I'm going to skip a little bit, what if we can offer telehealth support from a specialist? You know, we're doing this, or we're talking about it with neurology and psych. What if we could do it with palliative care? And maybe we can't use, you know, these models that they're doing every place else. But I think we need to talk about partnerships in the community. I don't have the resources to be doing all this. The hospital doesn't necessarily have the expertise, but can we come up with hospital home health or hospital hospice partnerships where we can leverage the resources and the expertise so we can take care of the community? I mean, sometimes that's a big ask because I think healthcare gets so siloed, but I really do think this is the only way we're going to get it into small towns. Oh, and this is the one that everybody's going to be like, never going to happen. Medicaid. Okay, Medicare is looking like it might come. What we have power in this in Wyoming is Medicaid. We can make it a benefit of Medicaid. And this is where I'm going to California, but Medi-Cal did this. And they have great template on what they expect for palliative care benefit, you know, for their patients there. I know that's a hard ask, especially when we get shot down all the time on Medicaid expansion, but palliative care saves money. It's better quality care for your residents and your neighbors, higher satisfaction, longer life, better quality of living. I think it's something that we need to talk about, even if they shoot us down. So that's all I have. You guys are welcome to call me, contact me any point in time. I get fired up sometimes. I think there's a lot of work to be done on this, but I think we can do it. With that, do you guys have any questions? I must have been awesome.
I thank you. Such an important subject, such an important talk, such an important service that you're providing. Thank you, thank you. And just a couple of comments. One is that, first of all, I love your slide about having a solutions-oriented approach. And one of the barriers in Wyoming certainly is the rural aspect. And you mentioned telehealth, and I think that's really important. Within the past year, I was involved with hospice with a family member, actually in Nashville, Tennessee, and was traveling pretty regularly to be with him. And we engaged hospice from Nashville. And one of the things that was offered in our first visit with hospice was they gave us an iPad. Mm-hmm. And then anytime there was something that was needed, all you needed to do was push one button. You didn't even need to put a phone number or anything. And then you got a hospice nurse and they could take you through the symptoms, or they'd discuss the symptoms, and there was a kit there in the refrigerator with everything from morphine for pain or anti-anxiolytics, all sorts of things. But it really, I think it's one of the silver linings of COVID is that it has introduced us to the power of telemedicine and the fact that you can leverage that technology, particularly in rural centers. My second comment is that from an oncologist perspective, I can't tell you how valuable your services are, and things are changing in our world, in the world of medicine very, very quickly. And treating cancer is a lot different than it was 10 years ago, certainly 20 years ago with the advent of molecular diagnostics and so forth. There's a lot more medical detective work that has to go into treating a cancer based on the genetic basis of the cancer. But I can give you an example from last night. I was the doctor on call and I took maybe 4 calls overnight. And not one of them was how to treat a cancer. Every single one of them was symptom management. Every single one of them. Bleeding, pain, vomiting, etc. And also, this is not about me, but it's a real life example. But I have a deadline for tomorrow at about noon to come up with a treatment plan. And it would be very nice to have a good division of resources and expertise in order to have symptom management and versus trying to come up with treatment plans. And those patients who are on palliative care, first, they get a better service because there's people who are designated to symptom management. And second, it's increasingly becoming a better use of resources to allow certain people to focus on treatment plans and others to focus on symptom management. And so it's becoming in this era of increasing specialization, it's becoming imperative and it's a better use of resources. And so I think that that's something that also should be leveraged and discussed when you're talking about funding and when talking about to legislative bodies, that in this changing landscape and the evolving specialization of medical care, that it is a good public service and it's better for everybody. And my third comment, and I don't pretend to be an expert in palliative care, and so I offer this as a comment and I'm interested in your feedback, but it has to do with the name change, because I think one of the barriers to get engaging palliative care is that people associate it with hospice. It's something which it's a verbal challenge that we've faced from day one. And because we are in this world and we deal with it a lot, I feel very comfortable with the concept that palliation, I define it as any medical or social interaction that is aimed at the alleviation of symptoms of disease as opposed to cure of the primary disease. And so it's symptom management. And if you tried to engage, if you approach a patient and say, we would like to involve palliative care, there's going to be an immediate sort of sort of recoil. Whereas if you engage somebody and said, we'd like to engage a team that's focused on symptom management, that's going to be a different conversation entirely. And I think that as a group, as a society, that semantics are very, very important. And I think that it's time to have a discussion about whether or not a name change is in order. And I don't know if that's something that you agree with or not, but
I would absolutely agree with it. Perception is reality. And, even in hospice, when people are ready for hospice, there's that cringe factor. Like, I can't believe that. I like supportive care. I mean, we could call it the live your best life care, have an awesome daycare, but, I think there's some truth to that. And, there is a little bit of a stigma to it. If we can find something else, the most important thing is that they're getting that care, right? It's like when I fed my kids like apples when they were kids and I said it was fruit sugar.
Did she really do that? She says she doesn't remember. Hey, I just want to speak for a moment on what we did with the Palliative Care Commission. And really, we were tasked through the legislature to find out what we really kind of knew the answer to already, and that was the lack of knowledge in our state about what is palliative care. And we did a big survey, and what came out of that is, people don't know what it is. And those that do, you know, wish we had it. And, you know, I guess it's kind of frustrating because really our task was to find out that we just don't have it, and we don't. One of the things that did come out of it was the only hospital in our state that was doing any palliative care was Cheyenne Regional.
Yeah.
And that's it. And so that's pretty sad, but I really appreciate your presentation. I really wish that you could talk to all of our state legislators and do this whole presentation for them. And then once again, it would be nice if we could get you in front of our primary care providers once again with this, because education is so key. You know, I agree to some good things are happening on the national scene, but we've got a long ways to go in Wyoming.
Right. And are we going to be ready for it? That's the big question. We're a little bit behind right now, but are we going to be ready when these things come down the pipeline? So yeah, absolutely agree. I feel pretty passionate about that. I mean, you guys had a great start in talking. I think the next question is, what's the next steps? You know, how do we make this a state that's friendly for it? You know, is it building infrastructure? Which you're right. In some ways, you know, COVID was very helpful. All of a sudden now, you know, I've Zoomed my PCP. I mean, people know they can do that. Is it building, you know, policies? I think, you know, there's some work to do, but like I said, I think this is the group that starts that discussion and gets the ball moving and moves it forward. Well, if there's nothing else, thank you so much. I very much appreciate giving the opportunity to come up and talk this with you.